Welcome everybody to this presentation on radiotherapy of inflammatory disorders on palms and soles. I want to thank also my co-workers here for this and our radiology assistants, Mrs. Wiesmer and Mrs. Farrell. So here are two typical presentations of inflammatory diseases on palms and sole. On the left-hand side, the diagnosis is not trivial. You can consider psoriasis. It could be also lichen planus. It could be a chronic eczema. So the diagnosis of these conditions can be very difficult. On the right-hand side, you see these cracks in the skin. So this looks more like a hyperkeratotic chronic eczema. So this type of inflammation you can see, for example, in the context of atopic dermatitis. Though there are a number of benign diseases for which intermediate doses of radiotherapy are used, for example, Dupuytren's disease, chronic eczema, or psoriasis. And you see that in all of them, the pathology is on the surface, at least in the eczema and the psoriasis. You see that the dose that is planned for these conditions is around 5 grays, up to 8 grays for psoriasis. The risk for normal tissues below that depends on the tissue associated to this, and on the palms and sole, I think the risk is quite low. And there are only a very few data available how the long-term efficacy of irradiation will behave in this patient population. So if you think about these diseases, we have to understand that in these diseases, we have an amplified conified layer, and then we have the epidermis. So in general, a penetration of 1 millimeter is fine if it's not too hyperkeratotic. And then in these situations, you might use 20 kilovoltage to have a penetration around 3 millimeters. So I show you here a picture from our old machines that we have used earlier. I like this machine because everything is so simple. So it has always a fixed combination of the voltage and the filter applied, which is, for example, aluminum for the 20 kilovolt. And also then you see here the connection with the currency and the counter for the treatment duration. I would really stress again that 12 kilovolts, 10 and 12 kilovolts, so Grant's rays are suitable for many of the patients. And only in cases where you have very pronounced hyperkeratosis, then 20 kilovolt might be applied. Nowadays, we use this modern treatment device that is quite easy to use and has a computer-based machine to start and to control the irradiation. You see here an example. So if you use this type of tubus, you can irradiate more or less the full hand. So this would be the setting that we are using for patients with palmoplantar inflammatory disorders. Still, we have to remember that irradiation is using a carcinogenic physical method, and therefore we have to think about the irradiation-induced risk. And based on the location, I would say that the risk is quite low. Nevertheless, I think irradiation is a treatment that should be restricted to elderly people and should be used if other options do not really manage to control the symptoms. For tinea capitis, for example, in children, there is a clear documentation that there is an excess risk of irradiation-induced skin cancers in this setting after radiotherapy. And on the skin in general, we have to consider that the carcinogenic effects of the irradiation will overlap with the effects of ultraviolet irradiation. It's estimated that the lifetime risk to develop a radiation-induced basal cell carcinoma is 0.006 if 100 square centimeters of skin are treated with a mean dose of 3 gray. So at the end, the risk is very low. And we still know that many patients are developing non-melanoma skin cancers without any irradiation. Still, if children are treated, for example, for keloids, which can also happen sometimes, long-term surveillance is advised for these individuals. Let's go into the literature. So this is a publication that has summarized the impact of irradiation therapy on chronic palmoplantar inflammatory diseases such as eczema or psoriasis. Here, low-dose irradiation was used, so the median total dose was 12 gray. There was most of the patients were treated with 0.5 gray in a fraction up to 5 gray. And this was a patient population of in different ages. Actually, the results are quite encouraging, since we see an improvement of the symptoms at the end of the irradiation and also at the last control. So many of the patients had a clear improvement as reported in this publication. Unfortunately, this publication has some shortcomings. So overall, the patient population is very heterogeneous. There are most of the patients are suffering from eczema. It's not specified which pretreatments, the type of eczema, so chronic hyperkeratotic one versus dyshidrotic, whether it was in the context of atopic dermatitis, no information on the duration of the disease. There is no information on concomitant therapies. And also the recruitment period for these 28 patients was quite long, so it took over 6 years to collect them. And at the end, we have to state that there is no information about long-term effects. In the same publication, there is this table on randomized controlled trials for the irradiation therapy of palmoplantar eczemas and psoriasis. And the summary is that there is really a poor documentation of a long-term benefit using irradiation. In general, I think we can say that there is a short-term improvement, but the long-term outcome in general is not really very promising. Nevertheless, we use irradiation therapies. You see here one of our patients where part of the palm is affected by a chronic eczema, not too much hyperkeratosis, but you see inflammation and scaling. Also, the fingertips are scaling, and the patient was really disturbed. And local corticosteroids and skincare did not improve the overall system. So the patient had an irradiation with quite a low dose, 6 grays here with Grant's rays. And you see here at the control, which was 3 months after the irradiation, a clear improvement. Unfortunately, we do not know how long this patient has profited from the improvement. Here, another patient which had a lot of problems, painful inflammation of the palms and sole, and a clear improvement after Grant's therapy. You see here the total dose was 12 grays. So these were 6 sessions, applying 1 gray per session. So at the end, these are like anecdotal cases that show that irradiation therapy can have a benefit in this patient population. Still, I want to stress that inflammatory diseases of the palms and soles need careful diagnostic workup. I think mycology is clear. Patch testing should be done, atopy screening and biopsies, but be aware that the biopsy result can be also confusing, because on the palms and sole, it can be very difficult to distinguish between psoriasis and eczema, for example. There are more and more powerful systemic treatments, and therefore systemic treatments might come first. These treatments are based on the precise diagnosis, so depends on the diagnostic workup. And only in chronic hand and feet inflammation, which can be in the context of eczemas, psoriasis, or lichen planus, that are non-responsive to systemic treatments, and the elderly population, X-rays are considered a reasonably option. And still, I believe that the data that are available today are not sufficient, so randomized clinical trials are urgently needed, and I would really recommend to do long-term surveillance in these patients to detect any radiation-induced cancers. Actually, I don't expect too much, but it would be important to have very reliable data in this context. And with this, I thank you very much for your attention.
Thank you, Professor Dummer. First question is, what is the maximum field size on the X-straw machine?
With our largest tubes, we have a diameter of 10 centimeters. So this is enough for a small palm or a reasonable palm. If larger fields are necessary, then we cut lead in order to have the area that we want to irradiate.
Okay, thank you. Next question, in your experience, how long are the remission periods?
That's a very good question. So outside of clinical trials, these patients are always treated with X-rays in addition to topical treatments and sometimes systemic. I would say in general, we should expect a positive effect for 6 to 12 months. There are very few cases of long-term documented benefit.
Okay, next question. This attendee has been using radiation with psoriasis and has seen psoriasis respond quickly to radiation, but then it appears to come right back. Her question for you is, would you retreat that area again? And what would you recommend as a retreatment dose?
That's a very good question. So our internal rules, well, they are certainly also subjective, but our rules are we do up to 3 treatment cycles. For one cycle, we apply a maximum dose of 6 gray. So if you repeat this 3 times, then you come up to a total dose of 18 gray. This we consider is acceptable in patients of advanced age. However, well, the topic is open and needs additional long-term follow-up.
Okay, you spoke briefly about the keloids treatment in children. Are there clinical situations suggesting the use of X-ray therapy in children for other indications?
Well, actually, in children, keloids can really be very bad. And I remember a few youngsters. So youngster is between 8 and 12 years that had rapid relapse of typically corrections of the ears. And these are huge keloids. And these children, they also don't like to be injected. Topical treatments do not work, so they undergo another surgery, and then we know that we can reduce the risk for a relapse if we immediately irradiate after surgery, and we consider this more acceptable than doing, for example, corticosteroids injection. So these are our youngest patients, but I would really say this is only a handful over the last 10 years.
Okay, thank you. And final question, is there a dose limit for these indications?
Yes, our internal dose limit is 20 gray. I know if we are using Gransway, we could go a little bit higher, but in general, we stick to the 20 gray limit per field.
Okay, I'm going to pose one more question because it's specific to Gransway since that came up. This attendee observes that the Grans is so soft that it's absorbed by the air, and that the larger the cone, the longer the tube, the target tube distance, and is wondering how you take this into effect.
Well, this is obviously correct, but we have a physical measurement and know what energy is coming if we prolong our distance. So we have 12 centimeters and 20 centimeters, and if we go for 20 centimeters, then the irradiation time is longer, and with this is compensated.
Okay, thank you so much.